Hello, folks. Good afternoon, and to those in other time zones, good morning. I'm Don Metz, Health Affairs Executive Editor, and I want to welcome you to today's media briefing featuring authors from the Office of the Actuary at the Centers for Medicare and Medicaid Services, who will present the latest national health expenditure projections through the year 2031. We're publishing this article today, June 14, as an ahead of print article in Health Affairs. The embargo time is 4 p.m. Eastern. We'll repeat that several times throughout the proceedings here. And we are very proud to present this work to our readers. We do so on an annual basis. Also proud of our longstanding partnership with the CMS's Office of the Actuary, whose work represents the gold standard for U.S. health spending statistics. We've been presenting their work on health spending since our first issue in 1981. I've had the pleasure of working with all the folks on the call here and many others at CMS over many years. And that's when we began our coverage of the historical spending trends. And we've also been presenting work on projections since 1991 and today's, or the projections. That's what we're focusing on here today. So pleased also to be able to provide you as reporters with an early look at these projection numbers, but news stories, again, should not be published prior to the 4 p.m. Eastern Time embargo. Before I introduce the authors, Health Affairs Senior Director of Communications, Sue Ducat, who will serve as our point of contact, has just a few words to say. Sue?
Thanks, Don, and thanks everyone for being here. Just a reminder that if reporters, if they'd like to see an embargoed copy of our study, feel free to email me at sducat@projecthope.org. I will put that also in the chat. Thank you very much.
Okay, so let me just introduce the speakers today. The authors of today's paper are all from CMS's Office of the Actuary, and we're delighted to have three of them. Actually, many more, but two will be presenting, and Sean Keehan, a senior economist, and Jacqueline Fiore, an economist, are both with the National Health Statistics Group and the Office of the Actuary. And John Poisel will also be, he's the Deputy Director of the National Health Statistics Group, also in the Office of the Actuary, will be available in the Q&A period. As I mentioned, others from CMS are on the call as well, and if one of the presenters or John will reach out to them, they will be available to answer questions as well. So without further ado, I will turn it over to Sean Keehan to start the presentation, and following that we will have question and answer. Thanks so much.
Okay, thank you very much, Don. Debbie, thank you very much, Debbie. Okay, so first, I would just like to thank Health Affairs. Don, your colleagues had done a lot of hard work to get the article to where it is, today to be published, and so we really appreciate all of the Health Affairs staff's assistance getting this article published. So again, Don, thank you very much for that, and please share my thanks and all of our thanks with your staff. Also, I'd like to thank the rest of you for coming and for your interest in our work. We hope to be able to answer all the questions that we can after the briefing. But as Don mentioned, we are also ready and able to, after the briefing, if other questions come up after the briefing ends. So, we're certainly going to try to be as responsive as possible to any questions that you have in order to get your work done. So I plan to go over half these slides, and then my co-lead author, Jacqueline Fiore, we'll go over the rest of them, and then we will take questions. All right, next slide, please. So this is an annual project in our office, and we produce projections by sector, payer, and sponsor, as well as enrollment projections with uninsured counts. And these projections are consistent with the historical accounts that were released this past December. We use both actuarial and econometric modeling techniques to generate these projections, and the Medicare projections are consistent with the 2023 Medicare Trustees Report. Also, our analysis assumed no changes in law throughout the projection period. And finally, more detailed tables for each projected year can be found at the link below on this slide when the embargo lifts. Next slide, please. This slide gives our four major findings. For the projection period, which is 2022 to 2031, we are projecting health spending growth to average 5.4%, faster than nominal GDP growth of 4.6%, leading to a projected increase in the NHE as a share of GDP to 19.6% by the end of the projection period. The insured share of the population is projected to be 92.3% for both 2022 and 2023 from gains in Medicaid as well as marketplace enrollment. After 2023, we are projecting lower Medicaid enrollment, but we are projecting that many of those people will have already had comprehensive coverage from another source, such as an employer. On net, across all coverage types, we expect a small decrease in the insured share to 90.5% by 2031. Finally, the IRA is projected to result in notable lower out-of-pocket spending on prescription drugs for Medicare beneficiaries beginning in 2024. Next slide, please. This chart illustrates our first major finding from the previous slide, with NHE growth seen in the blue line and GDP growth seen in the dashed gray line. NHE growth is projected to be slower than nominal GDP growth in 2022, leading to a decrease in the projected health spending share of GDP that year. However, over the full projection period, average NHE growth is projected to outpace average growth in nominal GDP by an average of 0.8 percentage point, leading to a health spending share of GDP getting up to 19.6% by 2031. Next slide, please. So this chart shows how we are projecting the impact of some of the COVID-19 related funding to play itself out over the projection period. And we thought this was important because it had such a large role in the last two historical years. And so we are projecting a decrease in spending on the combination of other federal programs and public health activity for 2022 and 2023, before those two categories have little or no impact on the last 8 years of the projection period. Next slide, please. So this table gives enrollment by insurance status and the uninsured for selected years for the projection period. Here you can see the increase in Medicaid enrollment, especially in 2021 and 2022, because of the continuous enrollment requirement of the Families First Coronavirus Response Act, leading to a historic high in the insured share of the population of 92.3% in 2022 and 2023. Then, with the end of the public health emergency, and with it the end of the continuous enrollment requirement, we are assuming that the disenrollment process that has recently begun, that will last anywhere between 18 and 24 months, will lead to lower Medicaid enrollment, especially in 2024. Although we are expecting the number of uninsured to increase, we are not projecting that the uninsured will increase by the same amount of the Medicaid enrollment decrease, because many of those impacted will have comprehensive coverage available to them through an employer or through a marketplace plan. By the end of the projection period, we are projecting the insured share of the population to be 90.5%, which is about where it was before the pandemic started. Next slide, please. Okay, so now this slide goes through some notable impacts from the Inflation Reduction Act that we discussed in the projections article. The IRA impacts start in 2023, but are most notable in 2024, when the 5% beneficiary coinsurance in the catastrophic portion of the benefit is eliminated, leading to a sharp decline in out-of-pocket spending for prescription drugs and faster growth in Medicare. In 2025, we see the impact of the $2,000 cap on out-of-pocket spending, keeping out-of-pocket growth negative in that year, and also keeping Medicare growth high in that year. And then with the start of the negotiations in 2026, we're anticipating this will lead to lower out-of-pocket payments for certain high-cost drugs, and also lead to slower expected growth in Medicare spending on drugs for the last 5 years of the projection period. Okay, and so with that concludes the slides that I was planning to go over. Jacqueline, are you on the call?
Yes, I am. Thank you.
Okay, fantastic. All right, so I will pass it to Jacqueline, and she will go through the rest of the slides. Thank you.
All right, so slide 8, please. Great. Thank you, Sean, and thank you to all in attendance for joining us today. Next, I will discuss the trends in enrollment, per enrollee spending, and total spending growth for the major payers. As you examine the graphs for each major payer, note that in some cases, the sum of the pieces may not add to the total due to rounding. This slide will discuss Medicare trends. Over the full projection period, average annual Medicare spending growth is projected to be 7.5%, and that is the highest projected average rate among the major payers. In 2022, a deceleration in spending growth compared to that in 2021 is attributable in part to the Medicare fee-for-service beneficiaries using emergent hospital care at lower rates during 2022. Also contributing to the slowdown was the phased-in reinstatement of sequestration-based payment rate cuts after a full year suspension of rate cuts in 2021. In 2023, a rebound in spending growth is attributed to an expected increase in fee-for-service hospital volume and intensity growth and faster Medicare fee-for-service per enrollee spending. Partially offsetting the projected increase are two factors associated with the end of the public health emergency in May 2023. The expiration of the skilled nursing facility 3-day rule waiver that waived the 3-day inpatient stay requirement to receive skilled nursing facility services, and the expiration of the 20% increase in payments to hospitals for inpatient admissions related to COVID-19. In 2024, lower projected growth is due to Medicare Advantage per enrollee payments and slower fee-for-service hospital spending growth. The slowdown in total Medicare spending growth is partially offset by an acceleration in Medicare prescription drug spending growth due to a Part D benefit redesign provision of the Inflation Reduction Act that eliminates the 5% coinsurance for catastrophic coverage. Last, for the 2025 to 31 period, Medicare spending growth is expected to average 7.8%. The Inflation Reduction Act's Part D benefit enhancements, which include the $2,000 maximum cap on out-of-pocket spending, raised Medicare spending in 2025 before drug price negotiation provisions linking price to the CPI, slow growth beginning in 2026. In addition, starting in 2030, the baby boomer generation will no longer be newly enrolling in the program for the first time since 2011. Next slide. Medicaid. For Medicaid, average annual spending growth is projected to be 5.0% over the full projection period. In 2022, Medicaid enrollment is expected to have reached 90.4 million. This historically high figure reflects new enrollees to the program, as well as many remaining enrolled because of the continuous enrollment requirement of the Families First Coronavirus Response Act. In 2023, states are expected to resume actively disenrolling Medicaid beneficiaries who no longer qualify for benefits, leading to a small projected decline in enrollment of less than 1%, or 0.8 million. Spending growth is projected to slow to 3.7%, in part due to this initial drop in enrollment. The major effects of the end of the continuous enrollment requirement are expected to occur in 2024. When Medicaid enrollment is projected to drop by 8.0 million, or 8.9%. Growth on a per enrollee basis is expected to climb to 7.4% in 2024, its highest growth since 1991, and reflect the rapid loss of many enrollees who tended to be younger and healthier and thus less expensive. Notably, although there will be millions fewer enrollees over the course of 2023 to 24, state Medicaid spending is expected to be 22.2% higher in 2024 than that in 2022, as states no longer receive the Families First Coronavirus Response Act's increased federal medical assistance percentage. Over 2025 to 30, average Medicaid spending growth is expected to increase, in part due to the disproportionate share hospital cap reductions set to expire under current law in late 2027. The growth rate at the end of the projection period would be lower without the disproportionate share hospital reductions. In addition, the final impacts of disenrollment are expected to be complete by 2025, and per enrollee growth is expected to slow during this period. Next slide, please. Private health insurance. Over the full projection period, average annual private health insurance spending growth is projected to be 5.4%. In 2022, growth in private health insurance spending is projected to have decelerated to 3.0%, following growth of 5.8% in 2021. This is the result of a projected slowdown in per enrollee spending growth in 2022 because of lower growth in use, especially for hospital services. Partially offsetting this trend is an acceleration in private health insurance enrollment growth from 0.3% in 2021 to 1.5% in 2022, led by higher marketplace enrollment growth and its American Rescue Plan Act expanded eligibility for subsidies. During 2023 through 24, per enrollee spending growth accelerates as a result of faster growth in both use and prices. Finally, growth in private health insurance spending is expected to slow on average to 5.2% during 25 to 31, partly because of the expiration of subsidies for marketplace plans and the associated 10% enrollment decline, roughly 2 million people, projected for directly purchased insurance. Next slide. Overview of hospital trends. Hospital spending growth is expected to be 5.8% per year on average for 2022 to 31, but as the slide shows, there are unique year-by-year trends. In 2022, hospital spending growth is projected to slow to 0.8% compared to 4.4% in 2021. Declining growth in use, in part attributable to pandemic-related hospital staffing issues, contribute to projected declines in private health insurance and out-of-pocket hospital spending, as well as growth in Medicare. In addition, spending for other third-party payers and programs, particularly from the COVID-19 Provider Relief Fund, is expected to have continued to decline in 2022. In 2023, hospital spending growth is projected to accelerate substantially to 9.3%. Growth in use is expected to rebound, and hospital price growth is expected to accelerate partly because of rising labor costs. These factors contribute to accelerations in growth for private health insurance, out-of-pocket, and Medicare hospital spending in 2023. In 2024, hospital spending growth is projected to slow, mostly due to Medicaid disenrollments discussed earlier. Over 2025 to 31, hospital spending growth is projected to average 6.1% per year as trends are expected to normalize and transition away from pandemic-related impacts on use and spending. Average growth reflects influence of the loss of the baby boomers enrolling in Medicare and the end of the disproportionate share hospital payment rate cap in Medicaid. Next slide, please. Overview of physician and clinical services trends. For physician and clinical services, spending growth is expected to be 5.3% per year on average for 2022 to 31. In 2022, total spending is projected to have grown 2.4%, slower than that in 2021, when growth was 5.6%. The overall deceleration largely reflects slowing growth in the use of physician and clinical services over the pandemic-driven decline in use in 2020 and the rebound that occurred in 2021. The slowdown in use is also consistent with the reporting of many people foregoing doctor's appointments in the midst of high economy-wide inflation, as well as limited availability of appointments and their associated wait times. In the case of Medicare, growth was also affected by the phased-in reinstatement of sequestration-based payment rate cuts. Last, as with the hospital spending projection, slower projected growth in physician and clinical services spending reflects declines in COVID-19 supplemental funding, particularly the Provider Relief Fund. In 2023, The acceleration in growth is largely due to much faster growth in spending for other third-party payers and programs. Expenditure growth in this category is expected to normalize after having declined significantly in 2021 and 22, as payments associated with the various federal stimulus efforts, including but not limited to the Paycheck Protection Program and the Provider Relief Fund, were expended over the period. In 2024, stable growth reflects the net result of a decline in Medicaid enrollment and spending, offset by the impact of rising private health insurance spending growth and faster price growth. For the remainder of the projection period, projected spending growth primarily reflects higher expected Medicare spending growth than that of private health insurance, largely due to faster enrollment growth projected for Medicare. Specifically, in 2026, private health insurance enrollment is projected to decline related to the expiration of marketplace subsidies, with very slow positive growth thereafter. In contrast, Medicare enrollment growth is projected to outpace private health insurance enrollment growth, particularly through 2029, as the youngest baby boomers age into the program. Next slide, please. Spending for retail prescription drugs is expected to grow 4.6% per year on average for 2022 to 31. In 2022, prescription drug spending growth is expected to have decelerated to 5.1%. Among payers, private health insurance prescription drug spending growth is projected to have slowed significantly, driven by reduction in spending on new drug introductions. In contrast, Medicaid prescription drug spending growth is projected to have remained elevated, partly as a result of continued strong enrollment growth. In 2023, growth is expected to slow somewhat, reflecting both slower growth in Medicaid as projected enrollment declines, and slower growth in Medicare, partly as a result of greater use of lower cost generic drugs for some categories of drugs within Part D. In 2024, some key aspects of the Inflation Reduction Act will begin to affect spending growth for Part D and overall drug spending, which on net result in similar growth to that of 2023. Medicare prescription drug spending growth is projected to increase significantly as a result of the Part D benefits redesign, notably the provision that requires Part D plans to cover the 5% coinsurance payments in the catastrophic portion of the benefit that were previously paid for by beneficiaries largely accounts for lower out-of-pocket prescription drug spending growth in 2024. In contrast, Medicaid prescription drug spending is anticipated to decline that year due to Medicaid disenrollments. Last, during 2025 to 31, prescription drug spending growth is projected to average 4.8%. Although spending trends for the major payers are expected to be influenced by their typical drivers, such as aging and introduction of new drugs, they are also expected to be differently affected by the Inflation Reduction Act. For example, provisions of the Act are expected to take effect and lead to lower out-of-pocket spending for beneficiaries and upward pressure on Medicare spending growth in 2025, when a $2,000 cap on out-of-pocket spending begins, and in 2026, when drug negotiations begin resulting in lower gross prices for several of the most expensive Part D drugs, are expected to lead to lower drug payments at the point of service. The Inflation Reduction Act is also expected to put downward pressure on Medicare's prescription drug spending growth, mainly as a result of the Act's inflation rebate provisions. Next slide. Major findings. We will now conclude the presentation by bringing back our major findings that Sean presented earlier in the presentation. We look forward to your questions. Thank you.
Sean and Jacqueline, thank you very much for that. As always, a lot of complex information, and really thank you again for all of your work on this. It's a very complex process, and you always make it look so easy in the end, and we really appreciate that. So we do have time for questions. Before that, I do again want to remind folks of the embargo time, which is 4 p.m. Eastern. That's today. If you do have questions, please use the raise hand feature in Zoom, And I will look for questions. And when I call on you, please do state your name and your organization. No questions yet. While we wait for questions, maybe I will just start with a question. You covered quite a bit the drug price negotiations of the Inflation Reduction Act. Just kind of a technical question. Do you model into the process any downstream effects of reduced out-of-pocket spending on things like slower disease progression and medical utilization? Does that get modeled in, or is that too complicated to do?
Yeah, no, Don, that's a great question. So that's definitely an area of research that our office is and has been pursuing for the last few years. As far as, do we have anything explicit? I don't believe that we do. John, do you have anything more about that? Yeah,
No, we've tried to build in all of the actual out-of-pocket impacts into the estimates and what will play out with Medicare's Part D beneficiaries and how that impacts the total out-of-pocket through each year of the projection. But in terms of like downstream impacts and things like on health utilization, and to the extent that might induce additional demand or affect disease outcomes and so forth, like that's a little bit beyond sort of where we live.
Mm-hmm. Thank you.
Sure.
We do have a question from Jesse Hellman. You're on mute.
Hi, thanks for doing this. Can someone talk about how hospital spending could impact Medicare?
Looks like you're done talking,
Medicare
so we'll lower
expenditures?
your hand in 8 seconds.
Sorry, I'm having Zoom issues. How
The
hospital
day's not
spending-
complete until somebody has a Zoom issue, so no problem.
How will hospital spending impact Medicare expenditures, both in the short and long term? Thanks.
For hospital expenditures,
Yes.
so in 2022, for Medicare, use was down significantly relative to the rebounds that occurred in 2021, following all the very slow use and negative use in 2020. We do anticipate that in 2023, that the utilization will bounce back considerably. At the moment, projecting 11% growth in Medicare hospital expenditures there. And then somewhat slower growth until we get through the 2025 through 2031 or 2029 part of the forecast, where growth is relatively elevated, generally falling between about 7.8% and 8.1% over that 5-year period. But by the time we get to the last 2 years of the projection, where we have the baby boomers, sort of their enrollment kind of their contributions to enrollment and contributing to elevated enrollment growth through 2029, that subsides. And by 2030 and 2031, we estimate or project that hospital growth will be about 6.9% in both years.
Okay,
Thanks.
thank you. And we have a question from Jim Parker.
Hi, Jim Parker, Hospice News. Thank you for taking the question. I was wondering if you have data on what proportion of the growth would be attributed to hospice or palliative care expenditures.
John, do you want to take that?
Yeah, I'm pulling up our distribution at the moment. We don't have a specific hospice number that we can give you, but what we could do is send you the relative breakdown and contributions or distribution rather of spending for each of the specific categories that we do reflect explicitly. And we'll do our best to add some guidance to that in response to your question.
That would be terrific. Thank you so much.
Okay, next we have a question from Dan Gornstein, and after that, we have Victoria Turner who's having Zoom trouble, and I'm going to read her question, but first we'll start with Dan Gornstein.
Hey, it's actually Leslie Walker on Dan's team using Dan's
okay.
Zoom. Sorry about
All right.
that.
Okay.
I'm with Trade-offs, the health policy news outlet. My question is, what is the role of extra payments or overpayments to Medicare Advantage plans playing in driving Medicare spending?
So when you say overpayments, what do you mean? That the fact that there are net costs associated with the MA payments to plans because it's not all spent on care, or if you could help us?
Yeah, I guess I'm thinking sort of overall, like the MedPAC report showing that, it's like 6%, more expensive to cover people through MA. I'm just trying to figure out kind of, I didn't see much in the report sort of calling out Medicare payments to Medicare Advantage plans. I just wasn't sure what you guys can say about kind of the growth of MA and how that might be contributing or not to overall spending growth.
Yeah, it might be best to direct you to the Medicare trustees report. We do break out net cost for Medicare MA plans, and we would be happy to send you the distribution that they account for total Medicare, as well as I lost my train of thought. We can send you that distribution as well as the growth rates for each
Okay.
of the levels and so forth. I would ask, again, you can certainly consult the Medicare trustees report for additional information. And if you'll forward your question back through our Office of Communications, we'll be happy to provide as much detail as we can.
Okay, sounds good. Thanks.
Okay, thank you. And as I mentioned, I have a question in the chat from Victoria Turner of Modern Healthcare. She's having Zoom issues, so I will read her question. I was hoping one of the speakers could expand on the projected savings in the Medicare program they attribute to the IRA provisions. Is there a ballpark number or rate they could use to quantify these savings?
Okay, so I can take a crack at that. That's a difficult question to answer because with the IRA, as I showed in my slide, the last slide that I went over, there were some provisions of the IRA that increased Medicare spending, like covering the 5% coinsurance in the catastrophic portion, and then the $2,000 cap on out of pocket. And then with the negotiations and the inflation rebates, that does lead to savings from the Medicare program. But as far as something to quantify what those savings are, I guess it's possible that our team could take a look at and see if we could give you a number, but like we don't have a specific number in the report, and so I don't have anything for you right now. John, do you have anything else that you could add?
Yeah, I was just going to ask that it might be good, Debbie, to pull back up that slide so that people can sort of get the visualization.
Yeah, it's slide 7. Go ahead, John.
We do. So Sean mentioned the 5% coinsurance impact. So Medicare will be assuming those payments, responsibility for those payments from beneficiaries starting in 2024. And he also mentioned the $2,000 maximum out-of-pocket cap that begins in 2025. And then we lump 26 through 31 together here, but that is 2026 is the first year where the negotiated prices for certain high-cost Part D drugs takes effect, and we anticipate that to accumulate. One thing I can point you to in the paper, we do talk a little bit in, let's see, on page 9, at the end of the Medicare section about the 2025 to 2031 portion of the projection, and there we do mention that the drug provisions, including the ones we've talked about, as well as the inflation rebate portion, or the inflation rebate provisions where linking drug price increases to CPI or economy-wide price growth. We do expect that over the course of the projection period, it's projected all these provisions together are expected to reduce aggregate drug costs by an average of 20%, as well as result in manufacturers decreasing rebates to Part D plans by an average of 45%. And it's not until 2031, if memory serves, that relative to expectations, sort of in a pre-IRA world, where we would expect Medicare to actually generate savings. Again, largely because in 2024 and 2025, the program is assuming, a significant proportion of out-of-pocket expenditures from formerly paid for by Part D beneficiaries. So I hope that's helpful.
Yeah, and we heard back from Victoria. She said, thank you, very helpful. So thank you for the response. I do not see any other questions. Let's just give it a second here. I don't see anything in the chat. I don't see any hands raised. Just give it a second. So it looks like no more questions. I think before we hop off here and before I close out, Sue Ducat, is anything else that you wanted to mention? I will mention again that the embargo time today is 4 p.m. Eastern time. Sue, did you want to mention anything else?
Just a reminder that if anyone wants a copy of the study, my email is in the chat and it's sducat@projecthope.org. And there's also something in the chat to reach the CMS Public Affairs Office for any other additional questions. Thank you.
Thank you, Sue. And again, thank you to everybody for your participation and interest. And again, my thanks to the entire National Health Statistics group, and particularly Sean Kean and Jacqueline Fiore and John Poisel for being here today. Again, really appreciate your work. This is really important and always heavily cited. Your work is so important and we really appreciate it.
Thank you very much, Don.
Thank you very much.
Yep, a pleasure. Thank you.
Okay, folks, thank you. We're adjourned.